because of its safety profile. And there was reduced effect on, in terms of diarrhea, hypertension, atrial fibrillation, and anemia in the zanubrutinib arm compared to ibrutinib. But there are multiple other sites that can be affected, including there can be off-target, on-target, off-tumor effect, such as the platelet being impacted, as well as the skin being impacted due to the action of this drug on EGFR receptor. In the biomarker analysis of this study, patients with CXCR4 mutation did worse, and patients with TP53 mutation did worse as well. So the answer to this, to my initial case, was that in the patients with wild-type genotype, you can use either zanubrutinib or ibrutinib, or bendamustine rituximab in the first-line setting. But there are some other big questions. We know BTK inhibitors. Out of the two, I would use zanubrutinib if available. There is a role of genomics. We already talked about it. But whether we should be using chemotherapy or BTK inhibitors, that's something that's still not very well known. We did an international retrospective analysis of age-matched patients who either received ibrutinib or bendamustine rituximab in the frontline setting. And the bottom line is, even though there were higher rates of response, complete remission, as well as VGPR in the BR arm, overall, there was no difference in the PFS rate, as well as definitely overall survival. The BROM study has been recently done by the Canadian group. What this study involves is adding another BTK inhibitor to bendamustine rituximab backbone. And this is for a fixed duration, unlike what we use BTK inhibitors as we have on a continuous basis. This is a very small study, but has so far shown favorable outcome of patients, although at a cost of higher toxicity. As you can see, many patients had infections as well as grade 3-4 neutropenia, and the follow-up is short. Pirtobrutinib is a non-covalent BTK inhibitor, a reversible BTK inhibitor that inhibits both wild type as well as mutant BTK, and even among patients who have been previously exposed to covalent BTK inhibitor, it's fairly effective. It is not yet approved in the setting of Waldenstrom, but it is a very, very well-tolerated drug. It's approved for CLL and mantle cell lymphoma and can be used off-label, at least in the US at present. And in patients who are progressing over BTK inhibitor as well as bendamustine rituximab, you have the option of using venetoclax, which is a BCL2 inhibitor, but using it on a continuous basis instead of fixed duration, as you can see was done in this study. After 24 months, once you stopped venetoclax, patients started to progress. So if you are using venetoclax, use it judiciously, but until progression or intolerable side effects. This is how we treat patients in the relapse refractory setting. If they have been previously exposed to zanubrutinib, then you can go with BR. But if they have not been exposed to a BTK inhibitor, use zanubrutinib. But if that's unavailable, then go with ibrutinib. And there are, as I discussed, multiple other agents in the for salvage therapies, including venetoclax, pirtobrutinib, bortezomib-based regimen, and even autologous stem cell transplant in select patients. The future is quite bright for patients with Waldenstrom macroglobulinemia. There are next-generation BCL2 inhibitor. There was some data presented at IWWM recently on sonrotoclax, which is a more potent BCL2 inhibitor. There was also some data presented on a BTK degrader, BGB 16673, which is also a very effective monotherapy, even in patients who have been exposed to BTK inhibitor as well as BCL2 inhibitor, with an overall response rate of upwards of 90%. And there is another radiopharmaceutical, iopofosine, which is currently being tried and is under FDA review. It is a phospholipid ether that allows iodine 131 to cross the WM cell membrane and attack the WM cell. And it has also been highly effective, although myelosuppression is a major side effect of that agent. We are very soon going to start a trial of anti-BCMA monoclonal or bispecific antibody, etentamig or AbbVie 353, targeting the WM patients in the relapse refractory setting. So stay tuned, and thank you.
Thank you very much, sir, for the excellent but brief in the management of Waldenström macroleucemia. Thank you.
So in the interest of time, we are not taking any questions and we'll be moving to the next session. So I would like to invite Dr. Sundar Jagannath, Professor of Medicine at Ikahan School of Medicine at Mount Sinai. He's going to speak on manifestations in MGS, including poems.
Thank you for the kind introduction. Let me have my slides. Okay. So Maman Chandi already introduced the subject of MGCS, but he concentrated on MGRS, which is one component. But he also, showed this particular slide that this concept of monoclonal gammopathy of clinical significance was brought to the attention, and the first paper was written by Jean-Paul Fermont, along with other French investigators. You saw Frank Brudeau and Ahmoud Jacquard. And you also saw the Italian AL amyloid specialist Giampaolo Merlini, and of course the Mayo Angela Dispenseri and Bob Kyle and Nelson Lung. So this was done. Why this was done? They first of all defined it, which Maman Chandi told you, that it's a small B cell clone or a plasma cell clone which is making monoclonal protein, and this monoclonal protein or the presence of the other mechanism which causes organ damage, and the B cell clone or the plasma cell clone is very small, and therefore that itself never constitute it as a myeloma or a lymphoma. So not meeting the criteria for active malignancy is very important, that the clone is very small. And there are also in MGRS cases were presented where you couldn't even find the clone very easily. So with that, why is this important? Because of major reason is, as long as you are able to clearly identify what the monoclonal immunoglobulin is doing, but there are cases where the mechanism itself is not clearly understood, but it is due to the presence of the monoclonal immunoglobulin, and that is poorly recognized and frequently undertreated. And that's what I'm going to say, why we should know about MGCS. So this gives you some timeline. I was quite surprised that the primary capillary leak syndrome was described in 1960, and so far I've seen only one patient who's under my care still at the present time. Next was Schnitzler syndrome in 1972. I've seen only one lady in 2005 who still follows me at this time. And then Poem syndrome is somewhat little bit more common. I've had 3 patients over the years. And then you have the Kahneman syndrome. We'll talk about it, ASOB, and IgM AL amyloidosis. I don't know why it is any different. And then you have Tempe syndrome and IgM Tempe as late as 2022. Now, this is a good slide. This slide, deck was actually given to me by Angela Dispensary when she had given the talk in 2020 for ASH educational session. So let us look at it. What you see in dark green there, that tells you which organ is really involved. And if you look at it, it could be broken down into three predominant categories. First column, you could see peripheral neuropathy or the nervous system. The second column is kidney, and you can see a number of green going along that column, kidney. And the third column is skin, which you could see quite a number of them, green column there. The rest of them are smattering. As you can see, in AL amyloidosis, of course, heart is involved, volume overload. Eyes are involved too, and you see those kind of things are there. But three major categories, which is what we need to concentrate on today. Peripheral neuropathy, and you already had an excellent lecture, not only the kidney pathology, but also the MGRS clinical from Maman Chandi. And then there is the skin involvement, which I will talk to you about. Then you see in the orange or red in the rightmost column. This is important because some of these diagnoses are purely clinical and some of them are purely pathological or histopathology. The kidney, you saw a number of slides, and obviously all the kidney disease is actually made by histopathology. It's not a clinical diagnosis. You cannot make it clinically, but you can suspect, but you have to do a kidney biopsy. But when you have neuropathy, it is predominantly, you're not getting the nerve biopsy in anybody, it's a predominantly clinical diagnosis. That's very important. And there is also, as I showed you, in capillary leak syndrome, there is nothing, no histopathology that you can obtain to prove that this was due to MGRS or MGCS. So this is important to recognize. Some are purely clinical, some you have tissue, and a few you could have both. So this is very good adaptation. Now, I'm going to only concentrate on two because you already had MGRS as well as the pathology, kidney pathology. So I'll talk about cutaneous manifestation and the neurological manifestation. So I broadly categorized it into four categories, and this is again was reported in the ASH Educational in 2024, and the actual publication is in Lancet Rheumatology in 2022. So first is systemic capillary leak syndrome, or Clarkson's disease, because that was defined originally by Clarkson, as I told you, very, very early. So what was the most important characteristic? I had seen only one patient. It was a female patient with IgG kappa monoclonal gammopathy, and she would have a catastrophic drop in the blood pressure, come to the emergency room and will have anasarca, and they will have to immediately try to manage her, sustain her, take her to the ICU, sometimes even intubate because there will be even pulmonary edema in this patient. What happens is there is tremendous extravasation of the fluid from the blood into the extracellular media, so plasma goes out. So there is hemoconcentration. So Angela Dispensary, in her education book, she said, look for 3H. One is hemoconcentration, the second one is hypotension, and the third one is hypoalbuminemia, because the albumin has gone into extravasation into the tissue, so severe hypoalbuminemia. Because the liquid went out, the blood gets concentrated. But it is very catastrophic, and you will find monoclonal gammopathy. And the treatment is very simple, giving IVIG, and you have to give it prophylactically because you can't predict when it will happen. Now, this is what you would not have known because I took care of a patient. Then this particular patient went on to develop multiple myeloma. And as usual, what should we give the treatment? Okay, give VRD, triple regimen. As soon as she got the Revlimid, she again collapsed and had to go to the emergency room. and things like that. So we had to resuscitate her. So next time we thought, oh, maybe it was 25 milligram Revlimid. Let's give 5 milligram of Revlimid. Again, she collapsed. So this is the one case, my experience, not reported. So I would not, and this patient has been managed up until today without the use of immunomodulatory molecule. So we do not know the full pathophysiology of the disease, but using immunomodulation causes cytokine release and causes this whole problem for this particular patient. I just wanted to bring to your attention. The next one I'll talk about is Schnitzler syndrome. And in this particular thing, again, you have some major criteria. One of the major criteria is the development of urticaria, itching type, and constitutional symptoms, fever, joint pain, lymphadenopathy. Those are all secondary criteria. So I had a patient like this. It is predominantly IgM monoclonal gammopathy. If you do the biopsy, you will find leukocytoclastic vasculitis, and you don't have the immunoglobulin deposition there. So this particular patient I came across and was diagnosed, managed in NYU. They did the biopsy. They didn't have a diagnosis. She went to Johns Hopkins. They did a biopsy. They looked at it. They didn't. She came back to me. At the time, I was working with an allergy and immunologist. He saw this patient and he told me, oh, this is Schnitzler syndrome. She has IgM and she has urticaria, and I'm going to give colchicine and you worry about the IgM. And of course, she responded to colchicine and I gave her rituximab and cyclophosphamide. She went into remission and she's still with me, as I told you, 2005. So this was a classic case where even in a major institution in United States, in Johns Hopkins, they couldn't make a diagnosis because the biopsy doesn't show the monoclonal immunoglobulin deposits there. You get a leukocytoclastic vasculitis. So that's why clinical, unless you think about it and you knew it, you will not diagnose it. That is why you need to know about MGCS. Okay? First two, if you had not known, you would have even lost the patient because it is catastrophic. The patient goes in. IVIG would save the person's life and you give it chronically. So now you know why we need to know MGCS. Okay. And then you have scleromyxedema. I've never seen one. And scleromyxedema. Myxedema, hypothyroidism, the phases. And scleroderma, and so this patient has cutaneous manifestation. The nose is much more broader. They have skin lesion. I will show it to you in the next. So that is a major criteria. And then the biopsy is very classic. You will have mucin in the skin. We talk about stomach having mucin or something like that. There will be mucin. There is increase in collagen and then increase in the fibroblast. So the histopathology is quite classic for this. And it is not the immunoglobulin deposition that you see. So that's why you need to know MGCS clinically in order to be able to put it together and come with a particular diagnosis. It's not straightforward like MGRS. So Maman Chanja had it easy because the kidney biopsy always gave him the answer. Anyway. So here we go, some of those things. So you could see D and E, the cutaneous manifestation of scleromyxedema, and some other, necrobiotic xanthogranuloma around the eyes, cryoglobulinemia, vasculitis. You can see the patient with Schnitzler syndrome, which is C, and Poem syndrome with the sclerotic changes in the bone. Okay, so Tempe syndrome, I've not seen one yet, and you could see Tempe is all acronym. Telangiectasis, usually in the face and in the chest, telangiectasis, elevated erythropoietin and erythrocytosis, monoclonal gammopathy, and perinephric fluid collection, which they have shown a big white arrow, and this is the kidney, and you can see the amount of fluid collection, perinephric fluid collection, and in this case I see mainly on one side, not on the other side, and intrapulmonary shunting, which gives the eye. And it has no immunoglobulin predominance, but yet the treatment is like treating myeloma or monoclonal gammopathy, getting rid of it, just like AL amyloidosis. There is a major criteria and minor criteria listed on the slide. So how do we treat them? So I put it in IVIG for scleromyxedema and capillary leak. And it needs to be given prophylactically in capillary leak, especially Clarkson's disease. And scleromyxedema, you can also give, clonal elimination of monoclonal gammopathy. Clone-directed therapy is absolutely required for POEMS and Tempe syndrome. And for Schnitzler's disease, I use rituximab because it's an IgM based, okay. The literature says anakinra, but I have not used anakinra, but I have seen only one patient. And cryoglobulinemia, treat the underlying cause. Now we'll go to monoclonal gammopathy of neurological significance. So this is very important because we quite often come across this one. So first step in diagnostic approach is MGUS and peripheral neuropathy is to exclude common causes of secondary neuropathy. This is common in elderly patients because MGUS is also common as you get older, and they also come to you with neuropathy, and they also have diabetes quite often. So you have to have all these, and then they see you. And we know we don't have to treat the monoclonal gammopathy of unknown significance. Why do we want to treat and we don't want to get involved in this case? So you have to first rule out diabetes, and in India, vitamin B12 deficiency, chronic alcohol use, or all those things has to be done. And another condition called CIDP, which is quite common seen in states. Now, this is particularly relevant for IgG or IgA MGUS because we will show you IgM is the one which predominantly has neuropathy. So this is a very good classification system, which I like it because it breaks it down to whether it is the IgM or IgG and IgA. IgM, again, it is divided into two groups, demyelinating peripheral neuropathy, and it is autoantibody tests are important, anti-MAG antibody, and there are other antibodies which are listed there, and we'll see them in the next subsequent slide. And then there is, of course, IgM. You can have cryoglobulinemia, mixed cryoglobulinemia, which can cause. And, of course, AL amyloidosis is always a diagnosis in any monoclonal gammopathy. IgG and IgA, it is very uncommon to be the cause of peripheral neuropathy, but you should suspect POEMS syndrome, which can cause this. And, again, cryoglobulin and amyloidosis. So if you have IgG and IgA MGUS patient with peripheral neuropathy, you should not immediately jump to conclusion it is MGPN or due to neuropathies due to the monoclonal gammopathy. Now let's look at the IgM because that's the major culprit. Clinical presentation, predominantly sensory neuropathy and length-dependent distribution. So you came up with that acronym DADS-M. We always saw this. It is always distal peripheral neuropathy, we know that, but somebody came up with this acronym, distal neuropathy, demyelinating, symmetric polyneuropathy, and monoclonal gammopathy, and they came up with DADS-M, but I don't know why. But we know peripheral neuropathy is symmetrical and distal and all those good things. So it is basically peripheral neuropathy, so don't worry about DADS-M and wonder what it is. And molecular studies, MYD88, we already heard the nice lecture on the Waldenstrom. Autoantibody test is very important if you have an IgM peripheral neuropathy, and you could see anti-MAG antibody is very important predominantly. And when anti-MAG antibody is not detected, then you have to look for other autoantibodies. And this is where it is shown here, other antibodies against gangliosides, anti-GM1, or against diacylacil, anti-GD1B, anti-GT1B, as shown here. And this is where you have another acronym here. But this acronym is useful because we do not come across this very often. That is, patient having chronic ataxic neuropathy, ophthalmoplegia, IgM paraprotein, cold agglutinin, and diacylacil antibodies being present, and that is called Canamat. And if you have non-detectable autoantibodies, then chronic distal sensory neuropathy, you have to still manage the patient. So IgM MGUS peripheral neuropathy, I told you how would you treat. It's basically like treating a Waldenstrom's macroglobulinemia. Now I will give you something little bit about POEM syndrome. This is again an acronym: polyneuropathy, organomegaly, endocrinopathy, monoclonal protein, skin changes. It's a relatively rare condition. And there are major criteria which are mandatory: polyneuropathy and monoclonal plasma cell, monoclonal gammopathy is important. And sclerotic bone lesions which are there, Castleman's disease could be there, and increased VEGF alpha. These are still an important criteria. And then you have a bunch of minor criteria which are listed there. And you need both mandatory major criteria, neuropathy and monoclonal gammopathy, and one of the other major criteria should be there. Presentation, again, you could have a distal tingling or numbness, painful in 10 to 15% of the patient. But what is important is that there is demyelination followed by axonal loss. Once the axonal loss starts, this patient will suddenly become wheelchair bound and become very weak, etc. And this is completely reversible. So treating them very quickly is very, very important, because progressive weakness within weeks or months, it's a rapid progression. So in the POEM syndrome, you could have localized in an area where you found sclerotic bone lesion, endocrinopathy, or skin changes. Then you just radiate that and it gives you the relief. But if it is systemic, then you treat again like systemic therapy with like myeloma. And this is one case. Mayo series shows autologous transplant is very effective one time, and the patient goes into excellent remission and they do very well. So in conclusion, peripheral neuropathy is the most frequent syndrome in monoclonal gammopathy of neurological significance, and it is commonly associated with IgM. That's important to remember. And then if it is IgM, you go through a whole bunch of testing for monoclonal antibody. You look for antibodies, MAG antibody and other antibodies. And I will stop here. My time is up. Thank you.
Thank you, sir, for a lucid talk and an interesting take on this particularly rare and rare entities which are rarely seen by us, and your experience in treating and diagnosing them. In the interest of time, we'll be moving towards the panel discussion.
Let us move on to the panel discussion for dysproteinemias. I would like to call the moderator for the session, Dr. Neeraj Siddharthan. He is the clinical professor and head Department of Clinical Hematology, Amrita Hospital, Kochi. Yeah, also one announcement. So tomorrow morning at 9 a.m. we have a session for the CPC. We have some printouts that are kept outside. So those who are interested can collect them from the registration desk.
Good evening. Can I invite the panelists, Dr. Anupama, Dr. Aditya, Dr. Rahman, Dr. Rajat, Dr. Sushant, and Dr. Ashish?
Good evening, everyone. I'm Dr. Ashish. I'm a consultant lab hemat in Tata Medical Center.
Hello, I am Dr. Sushant Vinarkar, Senior Consultant Lab Hematology and Molecular Genetics at Tata Medical Center, Calcutta.
Hi, good evening. I'm Khaliqur Rahman. I'm Professor in Department of Hematology, and I take care of the lab part in SGPG IMS Lucknow.
Anupama Borkar, Medical Oncologist from Goa Medical College.
Good evening, everyone. I'm Dr. Aditya Jandial. I'm a clinical hematologist at TMC, New Chandigarh.
Good evening, everyone. I'm Dr. Rajat Pincha. I'm clinical hematologist at Apollo Hospital, Guwahati.
So I think we have a very good mixture of laboratory consultants and clinical consultants. For me, I feel almost like an undergraduate student or a school student presenting with the professors in the front row. So it's a very nice experience. So probably the scientific committee wanted to introduce the term dysproteinemias. I still. So again, there are a lot of questions in my mind. What's a dysproteinemia? How is it different from an MGCS or monoclonal gammopathy of clinical significance? Well, I think a lot of the cases, I mean, we will discuss all of them are real cases and where we had problems. So I will start with this first patient, which is a 45-year-old female who presented with a bilateral pedal edema, dyspnea on exertion, and significant weight loss for 6 months duration. She didn't have any comorbidities. And when we investigated, she had a bilateral axillary lymphadenopathy, very small lymph nodes, and CT had shown pulmonary and subpleural nodules in bilateral, both upper lobes and left lower lobe. She had already, and also she had intra-abdominal nodes. She had already gone to the pulmonology department first and had a lung biopsy done, and which showed amyloid deposit, and also she had a lymph node biopsy, which also showed amyloid deposits. So, so how would you further evaluate this patient? I would put this question to any of the clinicians. Dr. Rajat, you want to take this question?
So his lymph node biopsy, her lymph node biopsy showing eosinophilic material suggestive of amyloidosis. So we just want to first would like to type that amyloid, and as well as we would like to look at the biochemical parameters of any paraprotein. Along with that, the bone marrow study to look at the plasma cell.
Yeah. So I think thank you very much. So. Whenever we have an amyloid, as Maman sir just pointed out, it may not be always AL amyloid, so it's important to investigate. And one of the first things that we investigate that we can, as hematologists, most of the amyloids usually get referred to hematology and medical oncology. So here, these investigations were sent. You can see immunoglobulins were almost normal. We have a kappa of 11 and lambda of 201, which is a lambda chain restriction. IFE was normal, and bone marrow had 3% plasma cells, and Congo red was negative, and FISH was also negative. And NT-proBNP and TROP-T was also additionally sent, and we found that an NT-proBNP was elevated. And the urine PCR was also high. So would you want to do any further investigations at this time, Rajat?
So since this lady had presentation in the form of dyspnea on exertion, pedal edema, so given the fact that NT-proBNP is significantly elevated, we should do 2D echo and look for the possibility of underlying cardiac amyloidosis in this case. Also, the value of proBNP should be seen in the light of serum creatinine, because we know that for patients who have low creatinine clearance, the proBNP levels may be elevated. So the cutoffs are different for them.
Okay. So yeah, rightly so. I think we proceeded with echocardiography. Echocardiography showed a concentric LV thickening and biatrial dilatation. There was impaired LV systolic function. The ejection fraction was preferred with a GLS of -11. And this was the ECG, which showed a low voltage complexes. So one of the important things in a cardiac amyloid which you could pick up. When I asked our cardiologist was, how would you suspect cardiac amyloid in a patient? Because it gets missed several times. So what he told us was that, if you do an echo and you find an LV hypertrophy and you do an ECG and it shows low voltage, if both are in both different directions, you have an LV hypertrophy and a low voltage complexes, and there a patient presenting with cardiac failure is often missed as amyloid. So that's something which will give us a clue. Now, as Rajat mentioned, this patient underwent further workup, underwent a cardiac MRI to further categorize the imaging, and also amyloid was typed, and it was an AL amyloid. So further, again, what would you treat this patient with, Dr. Anupama?
So the treatment will depend upon the affordability and the availability of, so it has to be myeloma-directed therapy. If daratumumab is available and can be used, then of course the latest recommendation is to go for Dara VCD. But in our country where that is not available, you would go just for VCD, like Cybor-D basically.
Okay, so so you would, if affordable, you would go for a Dara VCD, which is based on the Andromeda trial. So very rightly so. If not, you would give a VCD. So this patient was not able to fully afford it, but still could take 2 or 3 doses of daratumumab. So would you agree with this approach, or if you treat Dara, would you use completely Dara in all the cycles, or if the patient can afford some, would you use that?
I would completely agree with this approach. If the patient can afford a few doses and we know that it will give her some advantage, we could go whether to use it in alternate or first 3 in a row and then go to VCD. Will be a thing which will be decided on logistics, but I would support this because we know that we don't always have to go the whole length. If you can give them few doses and give them the advantage of that drug, I would not deny the patient. I would give it.
Dr. Aditya?
So definitely in the front line, especially in this patient with florid cardiac involvement, giving Dara seems to be it is quite logical to use it. We have not used it for abbreviated doses or lesser number of doses in any of our patients. I feel that early response, documenting an early response, there is data to suggest that response as early as 1 or 2 cycles of Dara VCD, if we can show significant reduction in the light chains, that is going to improve the outcomes, long-term outcomes.
So I think well said. There is some data to show that if you look at an early response, and then you could find out if the patient is responding to, especially the free light chain response.
Yeah, just want to add a point here that in real world, what we have seen in our practice at PGI, the patients with cardiac amyloidosis, especially stage 3 disease with significantly elevated pro-BNP, these patients are at risk of early death, sudden death, arrhythmias. These are quite common in these patients. So I would say maybe like if we can use a fewer number of doses to bring the light chain load under control, that may be reasonable.
So, Dr. Rajat, so this, when you actually send a patient a sample for typing, it probably will take anything between 4 to 8 weeks. So, like Aditya mentioned, if a patient comes with an advanced cardiac amyloid already, what is your strategy in your clinic? Would you wait till you get the typing, or would you start the patient on treatment straight away?
Sir, given the benefit of doubt and very poor prognosis of cardiac amyloidosis may not be initially Dara until we have proven to be AL amyloidosis given the cost confidence, maybe we can start with VCD for whatever benefit the patient has. I would have started.
Sir.
I have a question. Where was the mass spec done?
So it was in Toronto. It was sent to Toronto.
So my question is not that. See, if you had a definite elevation of light chain FLC was abnormal, you have cardiac involvement, you have lymph node showing amyloid, then I might say I won't wait for the mass spec.
Correct, sir.
I would go ahead.
Yes.
The patient whom I described didn't have a light chain, didn't have an FLC, and then to call it AL amyloidosis is wrong.
Correct, sir.
Here, I would say I wouldn't fight with you if you started treatment without the mass spec.
So we did start a bit. So what we do, sir, rightly as you pointed out, we discuss with the patient that we would send for a mass spec if they are affording it. But if their light chains are abnormal and the clinical profile is kind of convincing, we would start the treatment and say that we'll wait for the mass spec to come in. If there's any change, we might do it at that time, but this is what we feel. So most of the time we start treatment even before the mass spec comes, when you have a confirmed amyloid. So to Sushant, how difficult is it to get amyloid congruent positivity on a tissue that is sent to you? Or how easy is it to get it? Because this is some challenge that we face. Sometimes, the surrogate site biopsies sometimes do not yield amyloidosis.
So, if it is frankly present, then congruent staining will highlight the apple green Bayer fringes. But if it is very small amount, then it is a bit difficult to catch it.
Sorry to interrupt, but what I wanted to ask is, do you do congruent stain only if you find a deposit on the HND, or would you anyway do a congruent stain?
Yeah, routinely, if on HNE, if a clinician has suspected amyloidosis, then yes, we go ahead. Even if we are not seeing any sort of deposits and on, we still go ahead and do congruent staining. But yes, HNE also, if we are suspecting deposit, then we can go ahead and do the congruent staining.
So, Dr. Rahman, what are the sites of biopsies that come to you for amyloid?
So, a disclaimer that I am not a renal pathologist, so mostly we get bone marrow biopsy. And of course, as Sushant said, if the suspicion is that of amyloidosis, we go ahead with congruent staining, even if we do not have any deposition seen outrightly on the HE, also fine. So, but of course, as you said, the sites can be abdominal fat pad, rectal biopsies, lips, exactly. And then if we are targeting liver and kidney biopsies with staining for congruent and immunofluorescence is required to establish the type and the diagnosis.
So any of the clinicians can take this, but if a patient like this comes and, we had a biopsy of the lymph node and the lung here. Not very often it happens like that. You may find a cardiac is involved and which site would you go for a biopsy first? If there is no renal involvement, or if there is a renal involvement also. So would you go for a bone marrow, fat pad, rectum, or would you go for a renal or a cardiac first?
So I think as recommended by IMWG, so in patients who have clinical suspicion of amyloidosis with paraprotein in the serum or urine and organ involvement, so I think the involved organ should be targeted. Wherever we can't do the renal biopsy, we have seen that fat pad incisional biopsies, they have yielded better outcomes as compared to fat pad FNAC. So we have seen that in some of the patients, and it has been highlighted by Dr. Angelin, Dr. Dispensary also in some of her talks, that incisional biopsies yield for amyloid is higher as compared to fat pad FNAC.
Is there any difference of opinion among other clinicians?
Maybe we first look at the bone marrow biopsy, because it is already most of the patient it is done. So if it is positive, then we don't do any further. Otherwise, maybe fat pad.
I think this ASH 24, there was a guideline on amyloid, and it seemed to suggest that first go for a surrogate site biopsy, and the surrogate sites could be bone marrow, fat pad, and maybe rectal also. So the surrogate site biopsies, if taken together, may yield up to 75-80% yield. So bone marrow plus fat pad if you take. So it avoids in the need for a more complicated biopsies like renal or a cardiac. So cardiac, in the algorithm, the surrogate site biopsy seem to come first. Seniors can correct me if I'm wrong. but that was what recommended.
So I think one point that I would like to highlight here is that in multi-speciality settings, many a times we receive patients from different specialties. So if the patient has come from nephrology, the renal biopsy is most of the times already done.
Yeah.
For the patients who are presenting to cardiology clinics with the restrictive cardiomyopathy or hypertrophic cardiomyopathy, so wherever clinical situation permits, so in PGI they do undergo endomyocardial biopsy, and we have seen that in small proportion of patients, it is not AL amyloidosis but AA amyloidosis also there.
Yeah.
So in terms of biopsy, we would always go with the least invasive procedure. And in that case, I would say first, because the bone marrow biopsy has already been done, you try getting the Congo red staining on the bone marrow biopsy. But if you think it is difficult to bring the patient down for biopsies, you could go with fat aspirate and bone marrow biopsies simultaneously, which is what we typically do at our center. With fat aspirate, in 70% of the cases, we are able to diagnose upfront. With bone marrow biopsy alone, in 50% of the cases, it will be positive. When you add the two together, about 85% of patients will have positive results if you have AL amyloidosis. So it's important to do that as opposed to cardiac biopsy, as you indicated.
Thank you, Dr. Prashant.
But eventually, if you are unable to establish the diagnosis, go after the organ.
So the cardiac endomyocardial biopsy is usually a transjugular procedure. So it's also I mean, if you say it's not very invasive, but as Dr. Prashant pointed out, better to go for a site which is causing you less harm from the biopsy. And also sometimes, the organ response. So this I just wanted to bring in this slide. So you have the light chain responses early, sometimes with daratumumab and VCD, but the organ responses typically may lag behind by a few months. So in the interest of time, I'll move to the next case, which is a 48-year-old female who was under treatment in endocrinology, and she was also seen in nephrology. She had a diabetes, and she was diagnosed to have a proximal renal tubular acidosis with a low phosphorus, a normal potassium, an elevated alkaline phosphatase, a mildly impaired renal function test, and was diagnosed to have Fanconi syndrome and was on supplement. A renal biopsy was not done at that time. And she had a very trivial trauma and sustained a pathological fracture of the right metatarsophalangeal joint. Any of the panelists want to comment on your thoughts on this patient?
So I think proximal RTA is like, in addition to these findings like phosphaturia, uricosuria, and the other manifestations, many times we see osteomalacia also in these patients. So fracture can be because of, I would say, osteomalacia or vitamin D deficiency as such. So that is one thing that should be kept in perspective.
Dr. Ashish, you want to comment on that? On the biochemical profile of the RTA?
So, as you've already seen this, proximal renal tubular pathology and Fanconi syndrome, and there is a pathological fracture. As he rightly said, there are papers suggesting that osteomalacia can be associated with. And again, as there is a pathological fracture, probably as a pathologist, I'll first think of there is a pathological fracture, probably a plasma cell disorder can also be there. So probably I'll go with a bone marrow study again, if possible, or renal biopsy too.
Yeah, so thanks. So I think the endocrinologist who was seeing this patient was very sharp, and he picked up two things. One was this, although osteomalacia can be there in proximality, he thought this pathology, the fracture was a little, not accounted by the trauma. Second thing was the potassium, which was normal. In a proximal RTA, usually you have hypokalemia, but this patient had consistently normal potassium, so that was a atypical thing which was there. So again, they had already investigated, and when the patient came to hematology, the patient already had a kappa light chain which was elevated, and the M protein was not there. So clinicians, how would you proceed with further testing? Would you go for a bone marrow biopsy, or would you send the patient to a nephrologist for a renal biopsy?
Bone marrow biopsy, sir. Bone marrow biopsy.
Bone marrow biopsy, yeah, I think it's probably so. This patient had a bone marrow biopsy, and it was this patient is about probably now 13 years from diagnosis. So at that time, we had only available FISH, and no clonal flow cytometry was not available. So he had about 15% plasma cells. There was also a similar patient who had a low plasma cell percentage, where we did a renal biopsy, and there you can see the proximal renal tubular deposit. So in the MGRS, any of the pathologists, Dr. Ashish, Sushant, or Rahman, any of you want to comment about the MGRS profile that you generally see? Maman sir mentioned about it in his talk.
As in this electron microscopy, you can see a crystalline deposit there, the red arrow. So probably this is if the histomorphology would have been there, it would have been great. But if the crystalline deposit is there, if I'm finding in renal tubular cells, probably I'll go with a light chain proximal tubulopathy, or if there are histiocytes, probably I'll go with crystal storing histiocytosis. And then this immunofluorescence is probably highlighting the light chains there. Now probably the disease is due to light chain deposition disease, which is crystallizing and causing the light, tubular the pathology, the Fanconi syndrome. And if you go to MGRS, again the classical division has been the organizing and non-organizing categories of pathology, the organizing being the fibrillaries, the microtubulars and the crystalline deposits, and the non-organizing obviously the C3 glomerulopathies and the other, the TMAs.
Thank you.
I just want to add one point here that since this patient had diabetes for 9 years and there was a rise in serum creatinine, so I think in the context of renal dysfunction, diabetic nephropathy is always going to be a confounder in this case. So I think in the paper on MGRS by IKMG, so they mentioned that if the GFR decline is more than 2 ml per minute per year, the rise in creatinine is faster, then we should suspect an additional lesion. And secondly, in the context of a CKD where we are suspecting MGRS, so 3 things which point towards an MGRS lesion are presence of hematuria, proteinuria, and abnormal light chain ratio. So I think the 2 of them are present in this patient.
But if this patient did not undergo a transplant, this is the patient's treatment, Cybodex, and then maintained with bortezomib, dexamethasone. And then she was she interrupted treatment and then had a progressive worsening of the renal function and the kappa, and had to be restarted on treatment. So had she consented, would any of you have advised an autologous transplant here?
So this patient has an renal lesion, but if we see that the patient bone marrow has 15% plasma cell, and the biopsy shows a large collection of plasma cells as well, we don't have the imaging findings as such, the skeletal survey or any PET CT. So I'm not sure whether
she didn't have any
classify this patient as MGRS or myeloma. To me, if these cells are clonal, it should be more of a myeloma. And
I think this patient was diagnosed, you said 12 or 13 years ago.
Yeah.
So the kappa lambda light chain ratio is more than 100. So at that time, I think the IMWG didn't have that slim criteria. So by that definition, it might not be fitting into myeloma.
And even though it is not clonal, there was 15% plasma cell described. So so that's something to debate. So this was then subsequently reported here. So there was another patient, 46-year-old with hypothyroidism, who had multiple painful ulcers, and these were biopsied. It showed granulomatous lesions and then inflammation. There was no vasculitis described there. The initial evaluation was done in rheumatology. She was having anemia, which was 5.5, and then leukopenia. And then she was referred to because for anemia. When we evaluated, we had a kappa of 49 and IgG of 2,500, and then an M protein, which is not that low. Actually, 2 grams M protein is there. Further, when we did the bone marrow, it was 8% plasma cells in the bone marrow aspirate. When we did immunohistochemistry, there was 10 to 15% plasma cells in the biopsy and the 14-16 translocation. The whole body PET CT, although grossly did not show much lesions, the PET CT consultants reported as probable suspected query lytic lesion subtle. So the question is, this patient had 10-15 plasma cells and an anemia of 5, and how to treat this patient? Would you treat like a myeloma? We did treated, I discussed treating with triple agents, but she was not very keen. She was otherwise well preserved. So we gave bortezomib and dexamethasone initially, and the hemoglobin came up very nicely. So would you treat this as an MGCS? Because the anemia was probably very disproportionate, and the leg ulcers also healed after starting bortezomib.
So she's a young patient. I would probably do some more investigation. So like this morning we were in the Meet the Professor session, it was discussed that if you do a MRI and if you get these focal lesions, then you could even biopsy those lesions, because for a 48-year-old, it's very important to have your diagnosis first before you start therapy. So I would probably go 1 or 2 steps further and make sure that...
so as per the IMWG, she fits into myeloma, actually. Yeah. She fits into myeloma. But she didn't want to take transplant, she didn't want to take a triplet therapy, so she was like on doublet, and she's in remission and now on maintenance with fortnightly bortezomib and dexa. So she doesn't want to get transplanted.
So this patient also has anemia, leukopenia. There is some disc granulopoiesis in the marrow that has been mentioned. So I think more evaluation for that aspect should be done, because the cytopenias seem to be out of proportion.
And the cytopenias, everything resolved after starting bortezomib and dexa. Everything is come back to normal so quickly, even within first,
Why didn't she want the triplet? She's willing for dexa. What did she have against the triplet?
The lenalidomide, yeah.
Or cyclophosphamide?
Cyclophosphamide she didn't want because it was chemotherapy.
So Len, why was she against Len?
She didn't want. She wanted to come to the hospital and take treatment and go back. So she was from 200 kilometers away. And when we talked about the Len, the allergic reactions and all, she said, "No, I can't. I will come here and take treatment." So I also kind of agreed to her for that. If I had insisted, probably she would take it. Okay, so we are close. So there is another interesting case, which is a 34-year-old male. He was actually referred for an allogenic transplant for a pure red cell aplasia, requiring 2 to 3 transfusions per month. And he had a persistent anemia, very low letic count, and some monocytosis on the peripheral smear. Autoimmune markers were negative. Now, bone marrow aspirate was dry tap, we repeated, and then bone marrow biopsy is showing diffuse fibrosis with a 90% cellularity and some lymphoid infiltrate. And normal karyotype, flow negative, NGS for myeloid panels, no mutation detected, PET CT is normal, no primary malignancy is detected. So the immunotyping was done, which showed an M protein in IgG and kappa, and a repeat flow. The SPEP was done initially, the protein electrophoresis, which was negative. When we repeated it, it picked up a very small band, and the immunofixation showed a IgG kappa band also. So again, he was also started on bortezomib and dexamethasone. He became transfusion independent, And in 16 weeks, we repeated the bone marrow. The bone marrow was normal with MRD negative and monoclonal band is negative. I have not seen a case like this before, so we're just putting him on a maintenance. Any thoughts on this?
So all the molecular markers were negative.
Everything was negative. The NGS was negative.
So even if we consider this as autoimmune, but the amount of fibrosis which is in the marrow is not going in with the autoimmune. Autoimmune will have only low-grade MF1 kind of fibrosis. Diffuse fibrosis, MF2, MF3 is...
And the fibrosis was actually reversed when we repeated the marrow.
And with bortezomib only, she or he gained everything. The count is normal now.
Normalized.
It's very unusual kind.
So whenever so the myelofibrosis mutation negative myelofibrosis, I do check for immunotyping, immunofixation.
Sir, regarding this patient, it can be triple negative myelofibrosis who has...
Yeah, we thought of triple negative myelofibrosis because he was actually referred for a transplant for a triple negative myelofibrosis. But his fibrosis reversed with a clone-directed therapy.
Maybe a trial of thalidomide with steroids would have worked in either way, maybe.
Yeah, and there was this clone, and the clone disappeared also, so that we thought this is probably an MGCS, which then responded to the clone-directed therapy.
Was there sclerosis on your imaging?
The marrow stimulation was there, sir, in the imaging.
Was this a poems?
There is no
Because you're saying there was fibrosis, there was anemia, and you had a very small M-band. And everything went away with bortezomib.
But there was no sclerotic lesion in the PET, actually. There was no...
Nothing was.
No, sir. Okay, do we have time? If you don't have time, we will stop here because it's 6:15. Okay. So
thank you.
Thank you very much, all the esteemed panelists and teachers here. Thank you.
Thank you, sir. Thank you, panelists. Just a gentle request, kindly do not eat or drink anything inside the auditorium. Let us move on now to the oral presentations. It is said that without data, you are just a person with an opinion. Hence, the next session shall give you a better insight on the Indian data. I kindly request Dr. Sadashiv Gundeti, Professor, Head, Department Medical Oncology, Nizam Institute Medical Sciences, Hyderabad, and Dr. Velu Nair, Head and Chief Consultant, Hemato-Oncology and BMT, Apollo Hospital, Ahmedabad, to chair this session. I would also like to invite Dr. V.A. Arun, Clinical Hematologist and BMT Physician, Indian Naval Hospital, Ashwini, Mumbai, as the session coordinator. Sir, if you could please introduce the discussants.
Good evening.
Dr. Nair has just left, so Dr. Sadashivdu would be the chair for the session. He's just left. So we had a massive submission, I would say, this year with more than 100 abstracts submitted. And each of these abstracts were evaluated for novelty, quality of data, the translational value and impact. And in fact, we had a mammoth 25 mini oral presentations, 52 e-posters, and these are the chosen 6-1. So these have to be judged. And to the judges, I have made their judging a bit tough because I have given you the snapshot of the way the grid in which the marking has to be done. It looks a bit complex, but it's easy. But each student has to be judged on a paper, and then we will tabulate it. I'll just read out the names of the presenters because they just need to. So, Dr. Aishwarya, are you here? Yeah. So, Dr. Mridula, Dr. Rudra, yeah. Dr. Nikita, is she in? I think she's the fourth presenter. We will give her another 5 minutes. Dr. Sumit, yeah. Dr. Pratishta, yeah. So for the speakers and the presenters, I would say it's a like 3 top prizes waiting for you. So stick to the time plan. We have 6 minutes for your talk and 2 minutes to 3 minutes for discussion. So please stick to that. Without much ado, I would invite the first presenter. It will be Dr. Aishwarya to come on the stage.
Should I start? Aishwarya Das, and today I'll be discussing my study, my first ever oral presentation on exploring the association of TP53 gene aberration among routine diagnostic investigation in multiple myeloma patient. So I will not discuss more about multiple myeloma. It is an hematological malignancy characterized by proliferation of abnormal plasma cell in the bone marrow. So there are many risk stratification based on different parameters like presence of lactate dehydrogenase, albumin, beta-2 microglobulin. But one of the major classification is based on the presence of different cytogenetic abnormality. And the patient can be categorized into high risk and standard risk based on that. And it is expected that the patient with high risk cytogenetic abnormality has poorer outcome compared to the standard risk patient. So among the high risk patient, there are few cases who have TP53 aberration, which includes either deletion of 17p or TP53 mutation or both, that is double hit. So although these TP53 mutations are rare, but they have very adverse effect on the patient, and there are multiple studies which are proof that how this P53 gene aberration causes different poorer prognosis in multiple myeloma. So this TP53 mutation testing is done by next generation sequencing, which is both time consuming as well as expensive. Hence most of the lab miss this test, and the patient with only TP53 aberration are miscategorized at standard risk, which is not good for the patients. So my aim was to identify the association of TP53 gene aberration among routine diagnostic investigation in newly diagnosed patient of multiple myeloma, and I wanted to find out among the diagnostic parameter how can we suggest that for which patient we should go for TP53 mutation testing, if not for all the patients. So this was a retrospective data search where all the patients were categorized into standard risk and TP53 aberrant patient, and here we have exclude the TP53 aberrant patient which are in combination with any other high risk cytogenetic abnormality, and different parameters were compared between these two categories, and the statistic analysis was carried out using Fisher-Exact test. So this is the result. This is the heat map showing the presence and absence of different abnormality in different patients. Here orange indicates the presence of the abnormality and blue represents the absence of the abnormality, and each row indicates the patient. So seeing the first column, there are total 47 patients, and the first 30 patients were not having the TP53 aberration, and the last 17 patients were having the TP53 aberration. Among the 13 TP53 aberrant patients, 13 were with deletion and 4 were with mutation. Then the clinical parameters were considered that were renal failure, amyloidosis, plasmacytoma, the presence of M-band and bony lesion, but there were no significant difference of this parameter between TP53 aberrant patient and standard risk patient. Coming to the hematological parameter, we have seen for plasma cell leukemia, circulating plasma cell, anemia and thrombocytopenia, and we have seen that the presence of plasma cell leukemia and circulating plasma cell are more common in TP53 aberrant patient compared to the standard risk patient. And one major finding which we found in our study was that none of the standard risk patients were having plasma cell leukemia, that is more than 5% of the circulating plasma cell. Seeing the biochemical parameter, we have compared the elevated level of LDH and hypercalcemia, and it was seen that most of the TP53 aberrant patients were having elevated LDH and hypercalcemia compared to the standard risk patient. Then coming to the immunophenotypic profile using flow cytometry, here we have checked the immunophenotypic profile of abnormal plasma cell in the bone marrow. As we know that in multiple myeloma, abnormal plasma cells are CD45 dimmer and 81 negative, but we have found that in TP53 aberrant patient,
The abnormal plasma cells were CD45 positive and CD81 positive, which are more like normal immunophenotype, and that were significantly different in case of TP53 aberrant and standard risk. So after analyzing all the parameters, we have given a score to each abnormality based on their p-value, starting from 2 to 1. And we expected that if a patient has a score of 2 or higher, they are more likely to exhibit TP53 aberration. And it was also shown by this violin plot, which shows that most of the TP53 aberrant patient has the score of more than 2. So to conclude, there were 6 different markers of TP53 aberration, like hypercalcemia, elevated LDH, circulating plasma cell leukemia, and CD45 and CD81 positivity. And among in my study, no standard risk patients were having more than 5% circulating plasma cell or plasma cell leukemia during diagnosis. And if a patient has a score of more than equal to 2, they strongly correlate with the TP53 aberration, and hence TP53 mutation testing should be suggested for those patients, if not for all, which will in turn help in the patient management and clinical care for multiple myeloma. Thank you so much.
Thank you for a very nice presentation. My question to you would be, how did you decide 30 patients of standard risk and 17 TP53 is fine, the number you will have. So what sort of statistical analysis did you use to take 30 patients? Because the question here is, this is something which later will be using AI algorithms to predict. So the number of patients, the number of samples in all this has to be much huge in order to infer the conclusions that you have.
Yeah.
So what was the method behind that?
So this was a study for only 1 year, first of all, and TP53 mutation testing is still nowadays it is not been done in our institute for some years. So I got a data of 1 year, and among all the patients, there were more standard risk patients and more TP53 aberrant patients also. But we took only those patients for which all the data were available. So
Aishwarya, you are doing your PhD?
Yes, sir.
So where would you go from here? You have a derivation cohort where you are suggesting that if the score is more than 2, you should test. But where would you go from here as a PhD student?
Okay.
You have retrospective data. You come to a conclusion that if the score is more than 2, then you should test. But what would you do to actually prove it? So what is your next step as a PhD student?
My thesis is kindly okay.
You know what is a derivation cohort and what is a validation?
Yeah, we have to validate in a larger cohort first of all. But for that, I need the mutation data also, which is not available now because we have stopped doing mutation study in our department for some time. Yeah. For further, I have to do prospective study again in a larger cohort.
Your first slide didn't show the institute in which this work was done.
In PGI Chandigarh only.
Was it there, or I missed it? Huh?
It was there. It was there.
It was there.
Yeah.
So you pulled out 30 patients where you had data.
From 1 year 21 to 22, I have taken the patients who have all the data.
30. And out of those, 17 had a TP53.
47 patients. Among them, 30 were standard risk and 17 were TP53 with TP53.
If you look at the literature, would that be the proportion which?
No, definitely not. Because
so there's some bias in your selection?
Yeah, yes, it is. while I was doing the statistical analysis also, I followed that, I filled that, but there is some skewness of data, but I had to take the patients who have all the data. So this was
Second question is, there was no methodology slide. What is the standard methodology? Don't you do fish for everybody? Or you don't do fish?
Fish is done for.
Do you do plasma cell concentration before you do fish?
Yes.
All that should be mentioned. Whether there were other mutations, nothing. And you did a mutation and fish. How many of these were mutation plus and deletion plus? How many of these were only mutation? Was that data
for double
presented?
mutation, we have excluded double mutation.
That was not presented, no? Was it in your slides?
It were only deletion patients were taken and only mutation patients were taken. It was mentioned.
And how did you detect? You did NGS on all of them?
Sir, this is a retrospective data. So before I joined, only this data were available.
No, I know, but you're presenting, no? So you
Yes,
must
sir.
know how this data was derived, whether fish was done.
Fish was done.
All patients had
Yes,
fish.
fish was done.
And all patients had NGS done?
Yes, sir.
Thank you.
Okay, sir.
Thank you. Next, I would like to call upon Dr. Mrudula from Amrita Hospital, Kochi.
Good evening. My topic is circulating clonal plasma cells and its association with prognostic markers in multiple myeloma. So multiple myeloma, as we know, is a heterogeneous disease with varying clinical and molecular features among patients. Hence, there is a constant need for novel biomarkers to stratify patients in a robust prognostic group. Though multiple myeloma is a malignancy of plasma cells in bone marrow assessment is used only for differential diagnosis and not for risk stratification or prognostication. So circulating clonal plasma cell assessment provides a non-invasive, accessible, reproducible technique that can overcome issues with bone marrow assessment like hemodilution or the patchy nature of the disease itself. Aim of my study was to assess the circulating clonal plasma cells and its correlation with established prognostic markers in multiple myeloma and to compare the immunophenotypic expression of plasma cells in peripheral blood and bone marrow in these patients. Methodology. My study was ethically approved single-center prospective study conducted during the time period, January 2024 to November 2024. The sample was peripheral blood. It was processed by bulk lysis, stain and wash. Antibody panel was Euroflow MMRD panel for Q-tube 8 color, and the flow cytometer was FACS Cando 2. The events acquired was 1.5 million cells. Plasma cells were identified by the expression of CD38 and 138 expression. Abnormal plasma cells were identified by the underexpression of CD19, CD45, 27, and CD81. Clonality was determined by the clonal expression of either kappa or lambda in this case. The data on other biochemical parameters and cytogenetic abnormalities were obtained from the medical records of patients. Spearman's and Pearson's rank test was used to study the correlation of circulating clonal plasma cell percentages with other prognostic markers. The relative difference in median fluorescent intensity between the matched bone marrow and peripheral blood was calculated by the formula MFI peripheral blood minus MFI bone marrow by MFI peripheral blood. Now coming to the results and discussions, the number of patients were 20 and majority of our patients were under the age group of 65 and the median bone marrow plasma cell percentage was 33% by morphology. Bone marrow clonal plasma cell percentage by flow cytometry was 5.01% and the median circulating clonal plasma cell percentage was 0.036%, which ranged between 0.0065% to 1.865%. The absolute count was 2.15 cells per microliter, and majority of our patients were of high-risk patients, and these were the other patient characteristics. Coming to the results, coming to the figure 1. Figure 1 represents the patient distribution according to the clonal plasma cell percentage. So on the y-axis, it shows the percentage of clonal plasma cells, and in x-axis it shows the individual patient characteristics. As you move along the x-axis, each dot represents the patient distributed according to the increase in clonal plasma cell percentage. So the graph along with the heat map below gives us an idea about the correlation between the increase in clonal plasma cells and its indications in the patient characteristics. The table 2 shows us the correlation between circulating clonal plasma cells and its relation with existing diagnostic and prognostic markers. So we could get a statistically significant correlation with bone marrow plasma cell percentage by morphology, by flow cytometry, beta-2 microglobulin, RISS, and ISS staging. We did not get a statistically significance with LDH. Figure 2 shows the relative differences in MFI between bone marrow and peripheral blood. So individual expression of CD markers in bone marrow was kept as a baseline to look for the differences between MFI of plasma cells in bone marrow and peripheral blood. CD19, CD56, 117 and 81 showed much a lower expression of MFI in peripheral blood compared to bone marrow. And the figure 2b shows the phenotypic heterogeneity of clonal plasma cells between bone marrow and peripheral blood in one of our patient. So the circulating clonal plasma cells correlated with prognostic markers of multiple myeloma, and the study finding was concordant with the national and international studies that has been already published. Lower MFI was observed for CD19, 56, 117 and 81. And this phenotypic heterogeneity between peripheral blood and bone marrow may be because circulating clonal plasma cells have been accumulated from various sites of a patchy marrow. And to conclude, the limitation of a study, it's a small sample size and a single-centered study. Circulating clonal plasma cells, though not in practice, could serve as a valuable adjuvant to traditional prognostic markers. Phenotypic differences between circulating clonal plasma cells and bone marrow plasma cells that was observed need to be further studied, and beyond prognostication, the estimation of CTCs may provide more informative of a tumor burden. Thank you.
So what does the literature tell you about the surface markers on circulating plasma cells versus bone marrow? Do you expect that they should be similar or they would be different?
Pardon, can you?
So you said in your conclusion that the circulating plasma cells, surface markers were different than in the bone marrow, and that could be because the circulating plasma cells could be coming from different areas of the bone marrow, and that's why it was different. Is that what you said?
Maybe. The literatures have suggested it actually. There were 2 studies that I looked at, one from Athens and one from Japan. So their results also, the MFI was much lower for certain CD markers, like 56 and 81 was concordant with what we got. For them also, the MFI was much lower in peripheral blood compared to that of bone marrow. So they have suggested it.
Yeah. The mean fluorescent intensity variability is different, but the surface markers are likely to be different because in order for the cell adhesion to change, CD56 expression has to change, and that would let the plasma cells to go out in circulation.
So you are actually relating it to known prognostic factors, right? And you said you also used revised ISS.
Yes.
So what were the things in revised ISS? Was there any correlation with the poor cytogenetic abnormalities also, fish abnormalities?
Yes, sir.
How many patients had that?
Sir, majority of my patients were of high risk. I kept it on the table actually.
So Mridula, when you present data, when you say majority, I don't understand anything. It could be.
Sir,
It could be 11, it could be 10, right?
70%, sir.
70% means 14 patients were high risk.
Yes, sir.
So again, generally, if you are taking all myeloma patients in a given hospital, what would be the usual distribution of standard risk versus a high risk disease? Why is it that you are getting high risk disease?
Sir, I mentioned as my limitation the small sample size. The 20.
What was your definition of clonality? How did you decide that this population is clonal or not clonal?
Clonal expression of kappa or lambda. We isolated the
What ratio? Normally, what is the ratio of kappa to lambda in plasma cells? Normal, myself, any healthy person. If you have 2% plasma cells in the bone marrow, what is the ratio of kappa to lambda?
I forgot to say.
Normal ratio, I'm asking. Because you have done a study, no?
Yes, sir, yes,
so you have to tell me what the normal ratio is. If I have 2% plasma cells in my bone marrow and you do a kappa lambda, how will you find out?
Sir,
Okay, I'll leave it. Second question is, was this cytoplasmic staining or was it surface staining?
yes, sir. No, cytoplasmic staining.
So you had done cytoplasmic
yes, sir,
staining?
with perm, yes.
Okay. And what was your CV for each of these values? You said 0.048, right? Was there a range? I didn't see a range or a CV. You gave a table.
Yes, sir.
But I didn't see a range or a CV.
Sir, I put a...
There was?
Yes, sir. In the first table that I put in, with the patient characteristics, everywhere I had given a range, a median and a range.
Okay. Because you listened to today's talks, no? What is the sensitivity of flow for clonality versus NGS? Many talks today, no? Dr. Munshi gave.
Yes, sir. Yes, sir.
Huh?
Yes, sir.
Okay, thank you.
Thank you, sir.
Yes.
Thank you.
A study titled Prolonged linear-based induction for multiple myeloma has a minimal impact on stem cell mobilization with the use of GCSF and preemptive plerixafor. Before going to my study, I was just going rapidly through the current practice that after 4 cycles of initial induction therapy, either a stem cell harvest is done or the patient undergoes a high dose based ASCT. So various guidelines differs in the aspect of the minimum target that you need to harvest during the stem cell harvest. And most of the consensus is around 2 million cells, and the recommended optimum is around 3 to 5 million. So this is the current HSPC mobilization strategies that either only cytokine mobilization alone or a GCSF plus plerixafor based mobilization is commonly practiced. And in the case of remobilization, we use a chemotherapy based mobilization. And the impact of lenalidomide and daratumab can be extrapolated from the trials that master trial and Griffin trial, where the triplets, those patients who repeat only triplet like RVD, the 98% patient can be successfully mobilized with a median cells of 4.8 million. And in this RVD cohort, you can see 96% of patients who received only GCSF can have a successful mobilization. Another study also shows that more than 6 cycle of lenalidomide exposure can impair the mobilization. So coming to my study, the objective is just to find out whether there is any difference in the day 4 and day 5 stem cell yield when there is a prolonged lenalidomide exposure defined as more than 4 months versus less than 4 months. The study is a retrospective in design spanning from 2015 to 2024, and I will show the mobilization schedule that we start giving GCSF day -5 of the mobilization, and on day 4 we do a CD34 peripheral blood count, and from there we decide on to giving on plerixafor when there is a less than 10 cells, and the low volume apheresis model is usually preferred. And this is our target of achieving a more than 2 million cells, and at more than 3 million cells is optimal for a single ASCT. This is the study schema showing total 72 patient who was enrolled in the study, and this is showing various subgroups where the mobilization has been achieved. And in this overall cohort, only 2 patients in the lenalidomide more than 4 months, that is a longer exposure group, who has failed to have any mobilization. Apart from that 2 patients, all the patients has been mobilized. So coming to the result, the group who, this is a demographic profile and the baseline character profile of the disease. Here you can see the less than 4-month group has a median age which is older in the less than 4 months compared to the more than 4 months, that is a longer group. And the baseline high risk cytosine abnormality are more, that can be marginally more, because the p-value is just 0.06. Apart from that, everything is comparable. Coming to the main result of the kinetics of mobilization, the median day 4 counts and all those parameters, that's median day 4 CD34 cells, median day 4 CD34 cells with or without Pelixapor, median day 5 harvest and with or without Pelixapor are comparable, and there is no statistical significant difference between the 2 groups. And the need for a more than 1 session harvest is also comparable between 2 groups without any statistical significance. So after this, there are definitely many confounders that can have impaired the outcomes. So the first compounder is the age. When we have seen there is an unequal distribution. So how age has impacted the mobilization? This is a correlation curve that's showing a moderate level of negative correlation with a significant p-value. But doing a ROC analysis, the AUC under the curve is 0.55 for the day 4 CD34. That's showing a poor discriminatory capacity of the age to predict that whether the patient have a adequate mobilization or not. Similarly, the lenalidomide dose, because the various patient has received various doses, and across the dosing range, there is no significant difference between the CD34 ILD. But when combining age and lenalidomide dose, we can see the older the patient and having a higher lenalidomide dose, the mobilization, median mobilization is lesser compared to the patient who is older but received a less dose like 15 mg or 20 mg. Coming to the bone marrow cellularity prior to the transplant, there is no significant difference between the group. And similarly, the pre-ST disease status has no significant difference between the median in the patient. Here to highlight that the patient who receives quadruplet, there are 12 patients who receive DARA plus BRD. In that group, the median value of day 5 CD34 count trends towards a lower median, but this is not statistically significant. Might be the if we increase the number of the patient, then it could be a statistically significant. So coming back to the lenalidomide exposure again, here we can see the day 4 peripheral blood day 4 count is like showing a negative trend, and the trend line can be shown here. However, the day 5 IL is almost completely is marginally affected by the lenalidomide exposure. This could be due to the use of Pelixapor, which has advocated the impact of the prolonged exposure. Coming to the clinical implication of the data, is there any neutrophil engagement difference between the 2 groups? There is no significant neutrophil engagement or platelet engagement between the 2 groups. So finally, we did a prediction model which can predict a patient who is going to have a low harvest with a threshold of 3 million, and we find that pre-transplant PR, that the top one, has significance, and all of the rest has no significant association with a poor mobilization except the DARA VRD, the quadruplet, which has a marginal significance. And the model has a AUC 0.81, which can predict, which is a strong predictive value. So the conclusion is lenalidomide exposure in terms of initial induction didn't impact the stem cell mobilization. In older and age who has received higher dose, lenalidomide may impact mobilization. A biochemical response of PR impact mobilization, and the impact of a quadruplet regimen with daratumumab needs further exploration. Thank you.
Okay, thank you for a nice presentation. I'm still a bit confused after this presentation. So did all patients receive GCSF with Pelixapor?
No, sir. Those patients who has less than 10 cells on day 4 receives Pelixapor.
Right. So your conclusion is that if you're using GCSF with Pelixapor, then it abrogates the duration of lenalidomide?
Yes, sir.
And that is based, so how many patients receive Pelixapor?
The total 41 patient received Prelixafor.
And the total sample size was
72.
72. How would you infer that, GCSF with Prelixafor abrogates it? Because, you have one group who anyways receives GCSF, and there's one group which has used GCSF with Prelixafor.
So, sir, the initial data, like this data spans from 2015. So, nearly 30 patients who where we have not practiced then the day 4 CD34 count. In those patients, we have given only 3. In that cohort, we have given 3 Prelixafor for 3 patients. But when comparing to a cohort where there is no Prelixafor being used and the cohort where Prelixafor being used, there is no significant difference with the median value or any difference in the neutrophilic gamete or petrolatum gamete.
So did you compare the two groups in its all baseline characteristics in the era in which Prelixafor was not used? So are you saying in the cohort before whichever year Prelixafor was not available, how many patients failed mobilization?
So in the overall cohort, only 2 patients has failed the mobilization.
No, the one in which the GCSF was used predominantly with only 3 patients receiving Prelixafor. So that must be a period till 2017 or 18, right? Whichever the duration of the study is. So in that group, how many failed mobilization? Because the inference that you want to put is that with the availability of Prelixafor, lenalidomide duration may not have its relevance. So then the two groups that have to be compared is the one group in which Prelixafor was not used and in the other where Prelixafor was used. So in the period in which it was not used, how many failed mobilization?
So those 2 patients who failed mobilization has received Prelixafor, and there is no patient who has not received Prelixafor has failed.
Thank you.
I have one question. Did you look at the total white cell count in relationship to the CD34 count on day 4 and day 5?
Sir, we count the absolute number of CD34 count.
No. It's not my question. Total white cell count.
We look at
What was the difference, and why did you not provide a graph of the total white cell count in relationship to the CD34? Is it necessary to do that?
Yes, sir, because we have to calculate the absolute number of CD34 cells, we need the total WBC, because that is how we calculate.
No, but was there any correlation?
Sir, I have not looked up that.
Is it useful to look at, do you think?
I think when the denominator is the TLC count while calculating the CD4 count.
No, that is just the question of how you calculate CD34 in relationship to total count. But actually you don't do it that way at all. What was the method you used for CD34 estimation?
We would do by flow cytometry.
Yeah, so in that flow cytometry, you use beads, no?
Yes.
And it's an absolute count, no? It's not a relative count calculated on the basis of the WBC, is it?
So the report comes in the term of like the percentage of the total nucleated cells.
No, this is your research. So is a normal CD34 reported on the basis of the absolute white cell count or some other way?
No, sir, not basis of the absolute white cell count.
Okay, second question. How does GCSF work to mobilize?
So GCSF mobilized by breaking the adhesions, like the protease.
So which axis does it break?
Sorry, sir?
What is the axis that is broken to release stem cells?
That is a protease, so cell surface adhesion molecules, as protease, they break those protease to mobilize the stem cells.
I don't think it's protease. It's SDF. Okay? CXCR4 SDF axis is what is broken to mobilize. Okay, thank you.
Thank you, sir.
Thank you.
Thank you. There's a slight change in the sequence of the presenter. So we'll have the fifth presenter now. I would like to call Dr. Sumit from the Department of Adult Hematolymphoid and Bone Marrow Transplant Division, ACTRAC, Tata Medical Center, Mumbai.
Good evening. I will be presenting on outcomes of autologous transplant as a melphalan dose in patients with multiple myeloma, a 15-year retrospective institutional analysis. While melphalan 200 is standard conditioning, mel 140 is used in patients perceived to be at excess risk of toxicity. The only randomized study which compared mel 200 versus 140 had an additional 8-grade TBI in the mel 140 arm, and it showed that the median survival was higher with lesser toxicity than mel 200 arm, consequent to which mel 200 became the standard of care. Previous retrospective analysis, including a study from Lalit Sir's group from IMC New Delhi, have shown similar survival for mel 200 versus 140, especially in patients transplanted more than or equal to VGPR. However, none of these had MRD level data, thereby highlighting that there's positive data in the area of MRD. Our objective was, the primary objective, to compare mel 200 versus mel 140 for the median PFS and OS. Secondary objective was to compare PFS of these two for those who underwent transplant more than or equal to VGPR, transplant in first remission as per cytogenetics, as a pre-transplant bone marrow MRD, and as a pre-transplant PET steady status. An additional match pair analysis was also done. Over the last 15 years, 178 patients underwent 192 transplants. After excluding patients who underwent second transplant and relapse, and patients with tandem transplants in view of higher cumulative melphalan dose, we analyzed 176 transplants in 176 patients. It was a retrospective analysis of 2007 to 2022. Pre-transplant bone marrow MRD was done using highly sensitive flow cytometry with a sensitivity of at least 1 in 10 power minus 5, and any detectable MRD was defined as positive. We started doing pre-transplant bone marrow MRD from the year 2017 onwards. An additional match pair analysis was done for the following 6 variables in a 4:1 ratio. All survival and follow-up was calculated from date of transplant. Data was updated till 30th November 2024. Standard statistical methods were used, and a p-value of less than 0.05 was considered significant. Coming to the results, 134 patients were there in the mel 200 cohort, and 42 patients comprising 24% of the whole cohort were in the mel 140 group. As expected, the median age of transplant was higher, along with higher frequency of baseline renal dysfunctions in patients with mel 140 group. The gender distribution, ISS distribution, cytogenetics, and induction by doublet or triplet were comparable in both the cohorts. As you can see, that majority of patients underwent transplant in more than or equal to VGPR state and in first remission. In patients with available data, bone marrow MRD was negative in 62% and 52% in both the cohorts respectively. Pre-transplant PET was negative in 65 and 76% patients in both the cohorts respectively, and approximately 3/4 of the patients in both the cohorts received maintenance. At a median follow-up of 7 years post-transplant, the median PFS was 57 months and the median OS was not reached. Importantly, there was no difference between mel 140 versus 200 with respect to either median PFS or the median OS. In subgroup analysis, the melphalan 200 fared better for PFS, as you can see in the red curve for the melphalan 200 in the lower panels for the following subgroups: that is high-risk cytogenetics, pre-transplant bone marrow MRD positives, and pre-transplant PET positive patients. And the same is reflected in the forest plot for PFS here, with the maximum benefit in favor of mel 200 for patients who are pre-transplant PET positive. Additional results in other subgroups did not show any difference in PFS, and for OS, there was a trend towards significance in favor of mel 200. For the matched pair analysis of 141 patients, it revealed similar results as in the entire cohort. Most importantly, with respect to toxicities, significantly higher number of patients in the mel 200 arm developed a grade 3 to 4 mucositis, nearly double as compared to that in mel 140. There was no difference between the median duration of grade 3-4 mucositis, TPN use, and most importantly, the median day of neutrophil and engraftment rates between mel 140 versus 200. Our study has inherent limitations of a retrospective analysis. We have not compared it to non-transplant patients.
MEL 140 comprised 24% of the whole cohort, which is marginally higher than previously reported data. However, RTRM less than 1% probably justifies the clinical decisions. MRD negativity rates in our cohort were higher, 50 to 60%, as compared to other pre-transplant data, which is between 30 to 40%. Similar to other pre-maintenance data, between 45 to 65%. However, it is important to note here that unlike other studies where patients undergo transplant after 3 to 6 cycles of induction, the median time from diagnosis to transplant in patients in first remission was after 9 cycles of induction. A randomized control trial which compared Lendex continuous versus 3 cycles of Lendex induction, MEL 140, 1 year of Len maintenance showed no difference in survival. However, it is important to note that the induction was only a doublet. They used only 3 cycles of induction. The best response was less than equal to PR in 40% patients. And it was only 1 year of iron maintenance, thereby telling us that to take the results of this study with a pinch of salt. To conclude, half of our transplanted patients are alive without progression at 4.5 years post-transplant. MEL 140 is comparable to MEL 200 for survival except in patients with high-risk cytogenetics, bone marrow MRD, and pre-transplant PET positives. Less mucositis with similar survival means that MEL 140 is as intensive to the marrow and less toxic probably to the extramedullary tissues. And more prospective studies are needed to elucidate if less is adequate in the MRD era. And as a Maman sir's word, we are yet to find probably the sweet spot. Thank you. And as we all know, transplant is always a teamwork.
So, thank you very much for a very nice presentation. So, in your retrospective cohort, what were the reasons for choosing 140 over 200? Because this is not a prospective study where you can compare the two groups, isn't it? So, were there any reasons as to why did you prefer 140 over 200?
I could not show it because of paucity of time. In the MEL 140 cohort, 60% received because of GFR less than 50, 20% because of a cardiac comorbidity, which means EF between 40 to 50%, and remaining 20% received MEL 140 because of low DLC or low FEV1 on the pulmonary function test pre-transplant.
So then, can we translate results of data in patients with the reduced GFR to other people?
So the biology of a patients with reduced GFR is any day worse as compared to those with preserved GFR. But even in those patients, if it is showing similar survival, probably means that maybe MEL 200 is not required.
Would you use 140 now from now onwards in your patients?
So we need a prospective study to do that.
I hope that should have been one of your concluding remarks.
I think it was a very good presentation. And I have one question to you, that in your slide, you put greater than 140 to 200. What does that mean? That means somebody decided I'll give 180, somebody decided I'll give something in between, or why did you put that in your slide? It said greater than 140 to 200.
So I knew this would come to haunt me. In the 134 patients in the MEL 200 cohort, 132, which means 99% receive MEL 200.
MEL 200.
2 patients receive MEL 180. The justification I cannot give why did we reduce it to by 20 meters square. It was a clinical decision.
Okay. So I just have a comment that in the published data between 140 to 200, the PFS was better in those patients. The PFS was the 140 milligram group, if they were in remission, actually did better than the 200 milligram group. So the remission status at the time of transplant seemed to make a decision. So if you have a patient who's only in a VGPR, who has high risk, then you might say, I need to give 200. Whereas if he is in a good remission status, then you can get away with 140.
Yes, sir.
Thank you.
Thank you. We'll go on to the sixth speaker, Dr. Pratiksha. She's a senior resident, Hematopathology Department of ACTRAC, Tata Medical Center, Mumbai.
I'll present my topic on prognostic relevance of peripheral blood MRD assessment in newly diagnosed multiple myeloma cases. As we know, the bone marrow assessment in myeloma is the most important prognostic indicator, is now recognized as surrogate endpoint for drug approval. However, it is limited by its painful nature and technical difficulties. Recently, some studies have shown the clinical relevance of baseline circulating tumor cells in peripheral blood in myeloma. So, assessment of circulating tumor cells after initiation of therapy, peripheral blood MRD can be easily accessible and non-invasive alternative to bone marrow assessment. So my objective was to investigate the prognostic significance of peripheral blood MRD in conjunction with bone marrow MRD in newly diagnosed myeloma patients. We took 94 newly diagnosed myeloma cases. The patients were given 8 cycles of VRD. The patients were given 8 cycles of VRD. Then they were assessed with bone marrow and peripheral blood MRD. We took 6 to 10 ml peripheral blood sample and 1 to 2 ml bone marrow sample. The samples were analyzed using high sensitivity 13 color flow cytometry MRD assay given as below, with the sensitivity of 1 in 10 raised to power minus 6. Based on the MRD levels, the patient were either given MRD guided consolidation therapy or maintenance therapy. This was an example of our MRD in which the MRD level was 0.0001%. The abnormal clonal plasma cells were kappa restricted. They showed 56 overexpression and were downregulated for 81 and 19. Coming to the results of our study, the median age of our patients was 54 years, ranging from 32 to 79 years. The male to female ratio was 3.08:1. The patients were categorized based on ISS, RISS scoring. Based on cytogenetics, there were 10 patients with high risk cytogenetics. The patients were also categorized based on the response after 8 cycles of MRD. The serum immunofixation was also noted at 8 cycles. Looking at the MRD levels, there were 63% patients who showed bone marrow MRD positivity with the range of 0.0002% to 20%, and 19% patients were peripheral blood MRD positive with a median of 0.01%, ranging from 0.7 to 0.09%. In this, we can see those patients who had peripheral blood MRD positivity, in 18 patients, they were also positive for bone marrow MRD at higher levels, more than 0.01%. Comparing the peripheral blood MRD with the bone marrow MRD, we can say that the specificity of detecting is 100%. In this, we can see if the serum immunofixation was negative, there were also a significant number of patients who were positive for either bone marrow or peripheral blood MRD. Now, looking at the progression of our patients, the patients who were positive for serum immunofixation showed an early disease progression with a hazard ratio of 2.6, and those who were bone marrow MRD positive at levels of more than 0.001% also showed a early disease progression. However, median was not reached. They had a hazard ratio of 5.9. Both the values were significant. When the peripheral blood MRD levels were assessed, they showed a very high hazard ratio of 14 compared to the peripheral blood MRD negative patients with a median of 26 weeks versus not reached. When both the peripheral blood MRD and bone marrow MRD both were positive, the hazard ratio reached up to 13.5 with a significant p-value. Looking at the multivariate Cox proportional analysis, we can say that peripheral blood MRD positivity also has a significant p-value with hazard ratio of 12. We also looked at the ISS and RISS scoring and best initial response, but they did not reveal any association with early disease progression. Even detectable bone marrow MRD status did not reveal any association with early disease progression. However, detectable peripheral blood MRD is strongly associated with early myeloma progression and identifies the ultra high risk patients. Hence, regular peripheral blood MRD monitoring is effective in management and monitoring of disease progression in myeloma. There was a similar paper published recently by Spanish group which also showed that the peripheral blood MRD positivity patients were at a risk of 13 times higher risk of developing early disease progression. Lastly, I would like to thank Dr. Bhav Saib and Dr. Prashant Embare for their insights in this topic.
So Pratisha, good presentation.
Thank you, sir.
Despite the interruption. So what does it mean to you? It means that we should regularly monitor the peripheral blood, and once it is negative, then you will go for a bone marrow examination? Or you think bone marrow examination would not
can be negative?
Or you think that bone marrow examination would not be required? You said negative predictive value is low.
Yes.
Right?
Yes.
So what do you mean by that?
I mean that peripheral blood MRD can be negative, but bone marrow should be checked. But if the peripheral blood MRD shows a positive value, shows clonal abnormal plasma cells, then we can skip the invasive bone marrow procedure.
So do you have any data on immunofixation and the peripheral blood flow cytometry?
So we have looked at the peripheral blood MRD positivity at MRD. Then we looked at the disease progression based on the
No. The question that I'm asking is that if you are really talking about the criteria for response, right? So if you have an immunofixation positive, is it worthwhile doing even a peripheral blood typing?
Yes, there can be patients who can be negative on immunofixation, but the MRD levels may be detectable.
So how many patients were there like that?
I don't know. There are patients.
Did you look at the relationship? That's what I am asking you.
With the disease progression I looked at, I did not look at the immunofixation and MRD.
Right, thank you. Because generally when you are looking at responses, the first responses are the monoclonal protein, right?
Yes.
And then you look at the other things.
Yes, the responses were seen with MRD levels.
No, I can't answer on her behalf, but she hasn't understood. So basically the question was, did we look at the CR, VGPR, PR for all patients by the immunofixation, right? And then we also looked at the clonal plasma cells.
Yes.
Right? So basically, that's what Sir was asking.
Yes.
You actually showed a slide, if I'm not mistaken, IFE positive versus IFE negative on the outcome. So IFE positive people had worse outcome. So you also showed peripheral blood, tumor cells are present, and if they are there, their outcome is bad. If the peripheral blood this thing is tumor. So now the question is, how many proportion of patients who are serum IFE positive were also positive for peripheral blood? What is the correlation between that two? That was the question that was being asked.
If those patients out of 19, there were 16 patients who were positive for immunofixation at later time point with progression.
You had in your slide, you mentioned that there was a positive correlation and higher bone marrow MRD in those who were peripheral blood positive.
Yes.
Is that right?
Yes.
And then in your final slide, you said there was no correlation between negative outcome in relationship to bone marrow MRD positive, but it was there only in relationship to peripheral blood. Is that right?
Bone marrow
MRD positivity did not affect progression-free survival like peripheral blood did. Was that in your concluding slide?
Peripheral blood MRD had a higher hazard than the bone marrow, but bone marrow also showed disease progression. Bone marrow MRD in the levels of more than 0.001% also showed.
It did show.
Yes.
Because you mentioned that there was a good positive correlation between peripheral blood positivity and MRD level in the bone marrow.
Yes.
Correct?
Yes.
Can I ask you one question? What is the biological basis of clonality in myeloma? How did you define clonal? You defined, no?
The clonal plasma cells on flow cytometry.
Yeah.
Based on our aberrant expression of, they show a different expression than the normal counterpart, normal plasma cell. We find both the populations generally in all of the cases, normal will be different from the clonal plasma cell.
Yes, in terms of which CD markers?
The 45 dim expression, 56 over expression, 27, 87, 81 dim expression, then restriction in either kappa or lambda.
Is there any biological basis for the change in CD expression when it becomes clonal versus non-clonal? You understand the question I'm asking?
Yes.
What does the malignancy do to change the expression of these CD markers? Not sure. Okay. Thank you. Thank you.
Thank you, sir.
Thank you, Dr. Pratiksha. We'll move on to our last speaker for the day, Dr. Nikita Mehra. She's an Associate Professor, Medical Oncology in the Cancer Institute of Chennai.
Characterizing the DNA methylation landscape in monoclonal gammopathy of undetermined significance and multiple myeloma. I am presenting this data on behalf of my colleague, Subiksha. She's a basic scientist working with me on our projects, and she was not able to come here because she's got a PhD position in Germany and will be moving shortly. This is from the Department of Medical Oncology and Molecular Oncology at the Cancer Institute, Adyar. To quickly talk about tell you about the contributors from the Cancer Institute, we're from the Department of Molecular Oncology and Oncopathology. There are investigators from CMC Vellore, from the Department of Hematology and HemePath. From AIMS New Delhi, again from Medical Oncology and Molecular Oncology, from the Department of Oncology, Lab Oncology. Newburgh Center for Genomic Medicine in Ahmedabad, where it is again the Department of Molecular Biology, and the Department of Biotechnology from IIT Madras. We'd like to acknowledge co-research grant, DST SERB. To introduce the topic very briefly, we're looking to investigations into the methylation landscape of MGUS and multiple myeloma have demonstrated a phenomenon of global hypomethylation. So there is progressive global hypomethylation from the MGUS to the multiple myeloma stage, and this is coupled with gene-specific hypermethylation when compared to normal cells. And in patients with newly diagnosed multiple myeloma, this pattern of global hypomethylation is progressive, but is quite similar between multiple myeloma and MM. However, in patients with plasma cell leukemia or relapsed multiple myeloma, there is actually significant hypermethylation across various genes. So this study was aimed to provide insights into how these methylation changes contribute to the transition from MGUS to multiple myeloma, and we were looking to identify aberrant DNA methylation patterns in MGUS, smoldering multiple myeloma, and multiple myeloma, and we were specifically looking to identify epigenetic alterations that drive malignant plasma cell proliferation in the bone marrow. This is a slide on the patient characteristics for MGUS. We have MGUS and smoldering multiple myeloma. We have brief information on the fish for MGUS. I'm very sorry we were not able to include the patient characteristics for multiple myeloma. In multiple myeloma, we weren't able to obtain fish for most of the samples. So out of 18 samples, we just have 3 fish reports, complete fish reports, because in order to save cost, we of course go by limited panels, and we were not able to complete the panel. This was not budgeted for in the project. And the median age for multiple myelomas was 55 years of age. So essentially the project, the entire grant was actually for 2 components. One is aberrant DNA methylation patterns, and we're also looking at long non-coding, the expression of long non-coding RNAs in MGUS, smoldering multiple myeloma, and multiple myeloma. And we're looking to integrate these components and functionally analyze the genes. As of yesterday, we've completed the project at IIT Madras. So this is only the DNA methylation that I will be presenting. So blood samples were collected from 21 patients diagnosed with myeloma, 6 with MGUS, and 3 healthy controls. CD138 magnetic bead-based separation was conducted on all the plasma cells. And we did a methylated DNA immunoprecipitation sequencing to look at the genome-wide methylation profiling. Post-quality control, we had just 27 samples and 3 control. MEDIP sequencing, to very briefly tell you, we did a sequencing of the libraries to obtain strand-specific 150 base pair paired end reads on the Illumina NovaSeq 6000 platform. And for MEDIP-seq, we followed the standard protocols that are already published, but and for to look at significant DMRs, that is differentially methylated regions, we took a cutoff of a false discovery rate of less than 0.05 and log 2 fold change plus minus 2. So to briefly tell you about the results, these are the methylation, that is the genes. We looked at the entire, we did a global profiling of MGUS and multiple myeloma. None of the genes from smoldering, none of the samples from smoldering multiple myeloma were able to pass QC. And we identified a large set of hypomethylated genes and a smaller set of hypermethylated genes, as is already known. And the hypomethylation, we identified both in MGUS and multiple myeloma. We identified DNMT3B, and this is characteristically known to contribute to aberrant methylation. This is the genomic distribution in MGUS and multiple myeloma, and we saw a lot of these DMRs in intergenic and distal intergenic and intronic regions. This is just a Circos plot. This is the functional analysis. Again, what we clearly saw was that a lot of these cell proliferation and immune-mediated pathways really began in the MGUS stage and continued in the multiple myeloma. We saw commonly associated DMGs in both MGUS and multiple myeloma. 101 genes were observed to be commonly aberrantly methylated in these 2 study groups. And of course, we've to conclude, I will just mention these 5 genes: ACK, R3, BCL2, CC, ND3, CDH2, and MAP3, K7. And this, of course, contributes to plasma cell proliferation and survival, as is already known. And hypomethylation was observed in ANKRD11, KEAP1, and NCOR2. And again, because there's hypermethylation of tumor suppressor genes, that also contributes to progression of multiple myeloma from the MGUS stage. Thank you.
So what do you understand by having differences in hypomethylated area? And you said there was not a much difference between MGUS and multiple myeloma.
Right.
And you know that if you follow all the 100 myeloma MGUS patient, only 1% per year progress. So most of them do not progress. So you are telling me that there is absolutely no difference in methylation between MGUS and multiple myeloma?
No, sir. What we observed was differentially methylated genes. There are almost 6,800 in MGUS, and in multiple myeloma, we observed about 7,200 genes that were differentially methylated. Aside from that, what I did not mention was we looked at the purity of plasma cells through the NGS data set. In the MGUS, the purity of plasma cells was 55%. In multiple myeloma, the purity was the median purity was 85%, ranging between 65 and 95%. Of course, we looked at the already known multiple myeloma genes. We picked up those data sets from PubMed, and there's one publication. There's one publication from the French group that has clearly listed these multiple myeloma genes as well. And from that data set, we were able to identify 101 commonly methylated, aberrantly methylated genes in both the MGUS and the multiple myeloma data set. They are different, but we did not find, in terms of the number of genes that were aberrantly methylated, multiple myeloma, of course, was higher in number, but we did expect MGUS to be a lot less. We did not find that, sir. We found that MGUS also, there were a good number of genes. It was almost 6,800 genes that were aberrantly methylated in MGUS itself, sir.
Can I ask a very naive question?
So
if you were to compare myeloma versus MGUS, which were the significant changes that you found in methylation or hypermethylation or hypomethylation? Were there any, or
yes,
were there some which were there which might be important?
So there were some genes, again, when we tried to look at the absolute, when we tried to compare between the aberrant expression of those same genes between MGUS and multiple myeloma, we were actually not, based on the criteria that we set, an FDR of less than 0.05 and log2 fold change of plus minus 2, we actually could not find a significant difference in those genes that were...
So then would you say that there is no difference in methylation pattern between MGUS and multiple myeloma? And methylation does not have a great role in progression of disease?
So it absolutely has a role. If we change the cutoff, if we change the criteria for these, to identify these DMGs, we may have found some significant differences, but at the end of the day, we were trying to integrate this with long non-coding RNAs. And in that context, we decided as a group that we would maintain these cutoffs.
The questions I have for you, number one, you're presenting on behalf of
yes, sir.
us. Was the work done, including bioinformatics, by the person who you're presenting on behalf, or was the bioinformatics done by IIT?
Subiksha has done everything in the lab. IIT is doing the, so we've identified some genes, some targets, and we were doing the FACS work, so the apoptosis, cell death, etc., the transwell migration. Only that component, the FACS part for the cell line work, is done at IIT. Now, the NGS work, that is the sequencing of samples, was done at, including QC, was done at NCGM. We initially did it in Adyar Cancer Institute. We worked on 5 samples and sent it outside. Now, the issue is there was some delay in funding, so the samples were stored for a long time. And I don't want to mention which company I worked with earlier. I do not want to talk about that. But I found a lot of loopholes, which is why we decided to repeat this. Now, aside from that, NCGM did provide their Ahmedabad. They did provide their bioinformatics, but we were not in agreement because we could not understand the translational potential. So Subiksha's post-MSc biochemistry, and before she joined, it took her 3 months to join because DST SERB, there was a delay in the release of the grant. So in those 3 months, I requested her to study R and we would then discuss. When she came, she was ready to do everything. She did the bioinformatic analysis, and we have Deva Magendra Rao, who's a genomics expert. He checked everything, and he said everything was fine.
So there was a discordance between the Unipath and
No,
your
sir.
bioinformatics.
No, sir.
Ahmedabad.
Not a discordance. There was
The
not.
interpretation was different.
So they used softwares that we
Which
were
were
not very comfortable with. And ultimately, we wanted to, we were happier doing it by ourselves, because at the end of the day, DST SERB also provided the system for data analysis. And we did tell them we would do the bioinformatics. So we thought it was only fair to continue doing the bioinformatics in-house.
And you're not presenting the long non-coding RNA work. That's a separate presentation.
So
in this because you mentioned that was done.
So
but
that
it's not
was
presented in today's presentation.
No, sir, that was fully done. And the cell line work on LNC RNAs. So we identified 3 targets, and really exciting according to us, it's exciting. We finished that work just last evening with IIT Bombay.
Because
IIT
Nikhil
Madras.
Munshi mentioned in his talk, no, that there's a significant increase in long non-coding RNA in patients with myeloma, which seems to correlate with outcome. But you're saying there are specific non-coding RNAs which you all found,
so
which you all are following up.
Yes, sir. So we've identified the targets that we picked up from the bioinformatics. We then checked the expression in the cell lines. They correlated. Then we identified those targets. One, actually, the Siglec-5, which is an immune-mediated marker that was overexpressed in MGUS over multiple myeloma. Then there's MALAT1's antisense transcript, which is TALIM1. That we found overexpressed in multiple 2 targets. So that was interesting, exciting information. But sir, the data set is very, very small. The follow-up is very brief. So we don't have data on survival. So
thank you.
2 questions, Nikita. One is, what is the clinical relevance of the study? Secondly, how does it help us to understand the biology from MGUS to myeloma with this study?
So one thing is, we actually, so long non-coding RNAs, there was...
So we are talking about the hypomethylating and the methylation.
Right, sir. So, no, why I'm mentioning LNC RNAs is we found we needed to look for novelty in the project. And that was in looking at aberrant DNA methylation patterns of LNC RNAs. Because DNA methylation is separately published. LNC RNAs, there's already a lot. But this crosstalk, there isn't any data just yet for multiple myeloma. In some other cancers, it's already available. In terms of, I think, sir, what we wanted to, honestly, we really wanted to see if we could do this work, if we could do this in our labs, if we could collaborate with various groups and see if this was possible. And we've learned a lot from the limitations. There were several limitations. In terms of the translational potential of only methylation patterns, while you can look at the biological plausibility of, we are seeing at the MGUS stage itself that a lot of changes have already taken place. In terms of translation, that is treatment-wise, there is already some published data that they haven't, that is both DNMT3 inhibitors, that is Destibin, as cited in, has been studied in myeloma. It hasn't made a significant difference. The only translational potential from this entire project is to look at what it did to the long non-coding RNAs. We did not include that component because that study is still, it was ongoing until yesterday. But you can only explain why MGUS has progressed to multiple myeloma basis this data, not all that changes have happened. But in terms of treatment, I don't see anything, at least from our data, from what we have done. We don't know if we want to carry this forward.
But does it also explain how the MGUS has become a myeloma by your study on methylation?
So what we need, and Dr. Nikhil Munshi has done that beautifully, they have taken MGUS samples and Mount Sinai, the group has done wonderful work on DNA methylation. They have paired MGUS samples that have transformed to multiple myeloma. So they have the same patient who had MGUS.
We're talking about this study.
We don't have any of them, sir.
So this study is not being able to tell us the biology of how it transits from MGUS to myeloma.
So we need to follow up. So at CMC Vellore and at Adyar, we know which patients have had MGUS, and we need to follow them up serially. If they develop multiple myeloma, then at that point we could go back and study them, but I'm leaving.
You have a very small number of MGUS, isn't it?
Sorry, sir.
You have a very small number of MGUS that you would need to follow.
Only 8, sir.
Yeah, so I do not know whether... So currently, based upon what you have presented, as of now, all that we can conclude is that there is no difference in methylation between, on whatever you have studied, between MGUS and myeloma, and methylation problems start early in the onset of the disease. Is that correct?
So the no difference part...
so you haven't shown it to us, so I do not know
There's
what
a
is the
different set of... There are extra genes of multiple myeloma that have undergone aberrant methylation, but yes, a lot of methylation has happened.
That was my question to you. Was there a consistent change between the MGUS and this thing in extra genes, which you said you could not find?
So one thing is, it's possible that a lot of these, some of them have had intermediate high-risk MGUS. We've not taken those early MGUS cases.
You can only, interpret the data that you have in front of you. And then you can make hypotheses for future.
Right, sir.
But for current, this is the only thing that you can make out.
Absolutely,
isn't
sir.
it? Thank you.
Yes, sir.
What makes a worker bee different from the queen bee?
A worker bee from?
Different from the queen bee. Are they at DNA level different, or are they the same?
No, sir, you're talking about...
No, I'm just asking you a question. What makes the worker bee different
All
from
I can
a
tell
queen
you
bee?
is Subiksha is my queen bee, and I'm no bee.
I'll give you the answer. It's methylation.
So when you tell me queen bee, I only think of Subiksha. Beyonce and Subiksha. So, actually Taylor Swift. Thank you, sir.
Thank you for, I think, wonderful presentations by all the presenters. I think thank you all the judges. I think have taken a lot of time and energy. And all the presenters, I think at least more than 110 abstracts they have presented with so much of enthusiasm, and they have done good work. It doesn't mean that I think they are presented as a e-poster or a mini oral, and this one doesn't mean that they are not qualified for anything. Just take these all the inputs and incorporate into that one, make it a good publication, and don't get upset that you have done something good work published. You have presented here, but you are not something like not selected for this e-poster or that one. Just don't worry about all those things. You have done a good work, improvise the work, and take the inputs from all the experts here and incorporate those things into your presentation, what you can say, abstracts, and make it a good presentation and make it a good publication in a peer-reviewed journal. Thank you for giving us the opportunity, Rina Main and Jean, and all the judges. They have taken a lot of time. Maybe the results will be declared tomorrow, maybe at the time of validity function. Is it right, madam? Yeah, thank you.
All the presenters, the dignitaries and the judges for such engaging and thought-provoking lectures. We are indeed going back home today with food for thought. Now it's the end of today, so it is now time to enjoy the culinary flavors of Bengal. So dinner is being served on the first floor of the physicians' cafeteria. Good night. We'll see you tomorrow at 7:30 for the quiz finals.